is Mike. I'm a respiratory therapist in our NICU, and today I'm going to give you a little introduction to our Servo U ventilator that we'll use with our neonatal patients. I'm kind of going to go over some of the features of the ventilator, some of the manipulations on it that you guys will be able to do, and some of the modes and how it's used on our smallest little babies. So the first thing I'm going to go over with you is kind of how the flow, all the pressure gets to the patient through the tubing itself. Here you can see we have our little vent circuit. This is the same one we're going to use on our patients. The blue tubing is our inspiratory side, so the flow is actually coming through the blue tubing. It's coming through our heater and humidifier, so the gas is heated and humidified so the patients don't get too dry. It goes up the tubing here on the inspiratory side. This would be the ET tube to the patient. And then here's the expiratory side, so the flow comes back this way and then goes out the ventilator here, and then it will also give us all of the numbers on there as far as exhaled tidal volumes and inspiratory tidal volumes and then minute ventilation. That's how all of the flow of the ventilator works. So next we're going to go over some of the alarm limits that you're going to hear on the ventilator. When the vent does alarm, there's going to be a couple of different conditions that could happen. If it's alarming with a yellow color on it, it is a lower priority alarm. Something is going on, but it's not an emergency. If it's red, that means something needs to be taken care of immediately. Either the patient is disconnected, it's high pressuring, something's occluded. That is something that needs to be addressed right away. I'm going to go ahead and show you some of the alarms here. The respiratory therapist will set those, and a lot of times it's based on what the settings that the patients are on. So our alarm limit section here. So we'll have our peak pressure alarm, which is very important because we don't want to expose these little babies to higher pressures than we want to. So that'll usually be adjusted between 5 and 10 above whatever our set peak inspiratory pressure is. Our PEEP levels here, and it's usually a low level of 2. That will help us if the patient does become disconnected. Sometimes that's the very first thing that will alarm. That PEEP level will go down below 2 and it'll alarm immediately. Our respiratory rates usually set between 20 and 80. Some of these little babies can be very tachypnic. Sometimes they're breathing above 80 per minute. We'll set a little bit higher in those cases. Our minute ventilation setting here, just based on how many times a minute are they breathing and how much volume is going in, it's going to give us a number there. And then our last one, which we'll use kind of infrequently, is just an alarm limit on tidal volume. That is the same kind of thing. It's a protective thing. If there's too much tidal volume going in, it's going to alarm and tell us, okay, that this patient's getting too much volume. The other one is our sound alarm here. And you can see it can be quite loud. So with our little babies, since we're all in the room with them, we'll probably have it on a level of 6. That's probably generally where it's going to be. If it needs to be higher, we can put it higher. If it needs to be lower, we can put it a little bit lower, as long as there's somebody at the bedside, which there usually always is. And then the apnea time, usually about 10 seconds. If the baby's on a really low rate, we can turn that down a little bit lower to make sure that they're not going to go apneic and the vent won't alarm. Now we're going to talk about what conditions would make you take the patient off the ventilator and manually ventilate them PPV with the bag. Deep desaturation with no recovery, apneic event with bradycardia, you have a red alarm, the RT is not at the bedside, not available, any kind of question about the chest not moving, if you're concerned that the tube is plugged or is not in, you would just simply disconnect the ventilator, hook up the bag, start bagging, call your RT, call your ALS nurse, and evaluate what's going on. So next we're going to go over how the ventilator functions, the settings that you're going to see, and some of the manipulations that you're going to be able to do if the patient needs it. I'm going to go ahead and start it. Here we have some settings on the vent that you would typically see on a small neonate. And then go ahead and fix the alarm here. Alright. So here you can see this is the breaths of the ventilator here. We have our minute ventilation. Let me fix that alarm really quickly. There we go. Down here is your vent settings. You'll see here's your FiO2. So currently this particular ventilator is on 21%. Your PEEP, your rate, your pressure control above PEEP. So on this ventilator, what we're setting is the pressure control above the PEEP. The doctor will order the peak inspiratory pressure that they want. So this particular patient, the order would say 15 over 5. And how we're doing that is we're saying, okay, PEEP of 5 plus 10 is 15, and our peak pressure is going to be 15. Here, in this case, it's a little bit above that, but that can fluctuate a little bit. We have our pressure support here. Usually between 6 and 10 is common. Our inspiratory time. And here on the inspiratory time, that can be anywhere from 0.3 to 0.4 depending on the size of the patient. Over on this side is kind of where you're going to see here's your minute ventilation, here's the respiratory rate. Currently this ventilator is set on a rate of 30. We have 30 here. So where it's set, and this is what the patient is actually going to be breathing here. So this can be higher than whatever you have set if the patient is breathing above the ventilator. Your peak inspiratory pressure is here, and here are your tidal volumes and your minute ventilation there. Now we're going to talk about what kind of manipulations we can do with the ventilator if we need to do an O2 boost, which is what we have here, a manual breath, turning up the oxygen, all those things. If you needed just simply to turn the oxygen up before you're going to do your cares with your patient, or if they're having desaturation, you would press this, turn it up, and then hit the check mark. Now we're at 30%. There's also an O2 boost feature here. Let's say your patient's having desaturation, or you're doing a procedure and they're having a kind of a brief desat spell, and you just want to give them a little bit of oxygen for 2 minutes. You would hold and press this. It's going to give it to them for 2 minutes. This can be adjusted up and down. So we don't necessarily have to have it 60%. You can have it 10% above whatever your FiO2 is. Usually that's standard. If you need to change that, RT can do that, or you can do that as well by doing the maneuvers. So you go to the maneuver button, you would go to O2 boost level, and here we have it currently set at 30% above whatever our FiO2 is. So normally what we would do with these little babies, we don't want to expose them to a lot of oxygen all at one time. We'd usually have it around 10% above. And now you can see the boost is 40. 30 plus 10 is 40. If that's not enough, we can adjust that upward too. But generally speaking, 10% is what we would want to do. The other thing is the manual breath. Now sometimes these babies on a lower respiratory rate, 15 or 20, and they'll have an apneic spell while they're intubated, and they'll have a desat. Instead of taking them off and bagging them with the bag, it's very easy to do it with the ventilator. And it's safer that way because you're not going to expose them to different pressures than what you already have set here. The way to do that, you go into the maneuvers, which is where we are. You're going to hit the manual breath button and hold it down. That noise meant it gave a breath. It's going to give us a breath exactly what we have set here, the same I time, the same PEEP, the same pressure, and the same FiO2. So it's just a way to get extra breaths. So very effective and safer for the patient. Next, we're going to go over some of the modes on the ventilator that we would use in this unit. Mainly, there's two modes that we'll use. The first one is SIV pressure control with pressure support. That is a mode where we're setting a PIP and a PEEP and a rate, and then the patient can also breathe above that and get pressure supported breaths. The other mode is pressure support CPAP. That is basically just a CPAP is set, a pressure support is set, and the patient does all the breathing spontaneously on their own. Usually we'll use that mode if we're getting ready to extubate a patient. We'll try them on that to see how they're breathing, or if we need to keep them intubated for whatever reason and our settings on the vent are just too high and we need to wean them down to a lower mode before and to assess if they need to be extubated. Here is our mode. This is the main one we'll use. So there's a little information on it. But basically it will give you whatever breaths, and then the patient can also breathe above with the pressure support. And then our other mode is our pressure support CPAP. I'm going to go ahead and switch to that. And now the patient won't breathe at all unless it wants to, which is what I'm doing for it. So in conclusion, for you NICU nurses who are going to use the ventilator, the things that you can do: adjust the FiO2, use the O2 boost, and use the manual breath. And then of course, if something's wrong with the ventilator or the patient, you can take them off and just PPE with the bag. If there is any issues, always contact your respiratory therapist. If there's something going on with the ventilator, something going on with the patient, reach out to them. They'll help right away. Usually they're at the bedside with you.